speak, and the panel members keep their cameras on. I'm Councillor Habiban Zaman, and I'm the chair of the Adult and Health and Adult Social Care Scrutiny panel. If members could introduce themselves, please. Peter, do you want to start?
Thank you, Chair. I'm Peter Bradshaw. I'm a co-optee to the panel.
Liz?
Councillor Liz Smage, observing as Chair of Overview and Scrutiny. Thank you.
Alison?
Hello, I'm Alison Monroe. I'm a ward councillor and I'm a member of the Adult Health and Social Care Scrutiny panel.
Lynn?
Good afternoon, Lynn Keedy, a co-optee on the Kirklees Health and Adult Social Care Scrutiny panel.
Dave?
I'm Dave Rigby and I'm a co-optee on the panel. Thank you.
Leslie?
Hi, Leslie Warner, councillor for Combe Valley Ward, and I'm also a governor for the Hospital Trust, Calderdale and Huddersfield Trust. Thank you.
Okay, thank you. And we have Richard, who is supporting the panel this afternoon. Thank you. Okay, if we can move on to the meeting. We've had apologies from Councillor Afak, but is there any further apologies?
Not that I'm aware of, Councillor Zamamba. We were expecting Councillor Vivian Lees-Hamilton, who hasn't yet attended, but just leave that for the time being.
Okay. If we go through the minutes of the last meeting that was held on the Thursday, 24th of September, is there any matters that are arising from the minutes, or can we record them as a true record?
True record, please.
Can we have somebody second that?
Yeah, I'll second that.
Thank you. The second item is declarations of interest. Are there any members who wish to declare an interest that would prevent them from participating in any of the discussions?
Yes, Dave Rigby. I'm an ordinary member of Swift.
Thank you. Anybody else? Thank you.
I think,
okay.
Sorry to interrupt, Chair. I think Councillor Warner, did you mention that you were
I did say that.
The trust, yeah.
Yeah, so I'm a governor for the trust, which I mentioned earlier. So yes.
Okay. Thank you. Admissions of the public. This meeting is live on webcast. Do we have any members of the public wishing to speak? Richard?
No, we haven't.
Item 4, any deputations or petitions?
None received.
Thank you. Do we have anybody here to ask questions? Public question time, item 5.
There's none.
Okay, we will therefore move on to item 6, which is winter pressures.
Just before we do, can I just, it may not be the time to raise it now, it may be later, but sadly I couldn't make the last meeting because I was on holiday with no internet and I couldn't get in. And it's just when I looked at the minutes, obviously I don't know if they were, I wasn't there, but there is an issue that at some point I want clarification or more detail about, which I have mentioned before, which was the details of Lacala's decision to withdraw from its home care services. And I just, at some point, I'd like some more information on how that worked and the finances involved, etc. But I just want to make a note that I have raised this before. Okay, thank you.
If I can, through you, Chair.
Yes.
It was just to respond to that point, was when we had that financial discussion, that was a question that we did put on behalf of Councillor Warner at that meeting. So there was a response made, Leslie. That hasn't maybe been explicitly captured in the minutes, but it is actually available on the webcast. And if you want me to give you sort of more detailed response that was given, I can do that outside of this meeting if that helps.
Yes, please. Thank you very much.
Okay, I'll do that.
Thank you for that, Richard. I would ask Vicky that I appreciate the officers have put a lot of work into this area, and rather than individual presentations, if you would do a 5-minute overall summary, and then we go straight on to questions. I'm sure members of the panel have read the report, and if you give us a quick overview on that, I'd appreciate that.
Yeah, that's fine, Chair, not a problem. So what I do propose to do is just summarise the paper, and the detail, as you've said, is within the paper and also by each of the organisations who have contributed. It's in great detail. As members know, obviously the NHS declared level 4 yesterday nationally, so we'll just provide a brief update on the paper as it stands, bearing in mind that this is a rapidly changing picture, and as we invite in our various colleagues from the Trust, they'll be able to give you a more up-to-date position based on what's happening in the current situation. So, in summary, the winter plans that have been developed across the Kirklees patch are done on the acute footprints through our A&E delivery boards. And the approach that both A&E delivery boards have taken this year is very similar, in that both sides have combined their winter plans with the COVID reset plans that we were required to submit at that time. All partners are in attendance today, and they are all members of the A&E delivery boards, and the plans fully reflect the partnership preparations in the detail under each of the headings. For all of our partners, the plans tend to focus around 3 key themes. And one theme, the first theme that we've tried to address is safety and prevention, and that is safety for both our public and our patients, but also our staff. So that includes our people's stay well, self-care, how we can maximise the services that we have in our community to be able to support those individuals, and the alternative offers that we're able to do to help build that resilience. It also, in the detail, shows how we have developed some wraparound services and enhanced our wraparound services to be able to maximise the opportunities for our staff and our public. We've also included in the paper an update on optimising the flu vaccines, and again that fits in with the safety aspect for both our staff and our public. The second element that is covered in detail from all our providers is in relation to what our actual response is, our service response. And this is about ensuring that people get to the right place at the right time, and to get the right care once they are there. This is also about making sure that people can optimise the estate that we've got across Kirklees to make sure that we are maximising every opportunity we've got to be able to address the needs of our public and again our staff. And some of the examples that are in there, for example, our end-of-life offers and how we've developed that in partnership and enhanced that, so we are moving people through the system and getting them to the right place. And also how we're building on the capacity for 111 First, again, and doing the signposting. The third element that is in detail for each of the areas is about patient flow, and how we can maximise the opportunities of our patient flow to maximise the capacity that we have within the system, ensuring that people don't stay in hospital any longer than they need to be in hospital, but that we can get them out safely and promptly. And that's across all our services, so our acute providers, our mental health providers, and that we maximise that. Within the report, as you go through it, you'll find that there's detailed examples of the provision that we have enhanced this year. and also some provision that is new. So, for example, there's a section under Kirklees regarding the urgent community response model that has been developed, and that's new for this year. There's also examples in there of how we've maximised the capacity within our voluntary and third sectors to be able to support us. And from an acute trust perspective, that is how they've used the third sector to be able to support people stay at home, getting them out quicker, making sure they've got provision. In some cases, it was about delivering the medication at the right time. So what we've tried to do is show that through the report to evidence how the whole system of partners is working together to support our whole population. So that's just a really high-level summary, and the detail, like I say, is in the report. And then I'd just like to be able to hand over to our acute trust, the mental health trust, and Locala to be able to give you an update on the current position, Chair. So I don't know, Helen, would you like to go first for CHFT?
Okay, thank you. Hi, I'm Helen Barker, Chief Operating Officer for Huddersfield Foundation Trust. So I think just to echo Vicky's point, it has been very system focused in terms of how we're trying to address both our approach into winter and our COVID response. I think the challenge at the moment is it's extremely pressured. So we are already in excess of the amount of beds that we had planned in terms of from a COVID perspective on top of our normal winter. And on the back of that, we've made a decision at the back end of last week that we needed to step out of all of our planned care so that we had enough capacity in place to support our emergency and urgent admissions, and we've also enacted the surge plan with our local independent sector providers so we can increase the amount of capacity that we've got in place for patients who require access for cancer. We haven't stepped out of all of our outpatients yet or our diagnostics, but that is a position that is under review on a weekly basis given the numbers. The challenge at the moment is the different cohorts of patients who need admitting. So the COVID positive, the COVID negative, the COVID queries, and we still have issues within the trust that it's the same as the track and trace. If we have patients who've had a negative patient who's had a contact with a positive patient, then we need to isolate them. So it's not just about our overall bed capacity, it's around the type of beds that are available. We have enacted System Gold across Calderdale and Huddersfield a couple of weeks ago, very much focused on the transfer of care, and so getting patients out who need social care support. We're actually the numbers continue to rise, which is giving us some pressures, and that's not because people aren't working really hard at it. I have to thank my local authority colleagues in terms of the response that we've had to that, but there is just an increasing demand for that type of capacity. So as quick as we manage to support a patient into an out of hospital facility, we've got another one who needs that. And what we've done this week is we've moved into a step change in terms of from a primary and community services, what else from a planned perspective could be stepped down, that we can make sure that we're diverting all of our capacity to patients who are requiring emergency or urgent access. The challenge that we've got this time compared to wave one is that actually lots of patients didn't come to hospital and we had lots of empty beds, so we had about 45% bed occupancy. We're now running in excess of 90% bed occupancy, and that is stretching our staff availability. So it's challenging. I've got every faith in my own colleagues within the organisation and the partnership arrangements and the maturity of those that we've got across the system, but it is going to be a challenging winter. And there's some difficult decisions that we're making sure that where possible we're making as a system. We're being clinically guided by our senior clinicians in terms of doing that. but there are patients who will be waiting longer as a consequence of this, and probably in particular for this this committee, that as part of our plan to ensure that we had some capacity to treat cancer patients within Calderdale and Huddersfield, we have closed the birth centre again at Huddersfield. All of those patients who were booked in have been contacted, and they've been offered alternatives within CHFT and using the same staff, but that's allowed us to have a dedicated 7-bedded unit that we can continue to bring cancer patients in, and that's the only planned capacity we now have across our 2 sites. But I'll stop there. I'm happy to take any questions.
Thank you. Can we move on to questions? And again, I'm conscious that there may well be some overlap of the next item. Peter?
Thank you, Chair. This is a question for CHFT, actually, so it's convenient that Helen just spoke. I have a number of brief items, please, of CHFT, Helen, which they interdigitate and they perhaps coalesce to some extent, but and I pose these against the predicament with which you find yourself. You know, I don't want for 1 minute to underestimate that your priority is to treat very, very sick people. I think we all understand that, and we all understand the rationale for doing what you've done. But we had a memo from you on the 10th in which you said, in addition, the delivery of any surgery at the hospital will cease. And you go on to explain that it will be moved, hopefully, to the independent sector. My question really is really one I pose on behalf of the people of Huddersfield. Firstly, it's about the quality of the replacement surgical activity in the independent sector. And really, does it meet your standards in terms of things like appropriate medical cover? Because private hospitals don't have a lot of medical cover. Well, you know, what's going to happen to it overnight? Will there be any doctors there? And what's going to happen to nurse-patient relationships? So that's my first point, please.
Okay, thank you. So, so in terms of the quality of the independent sector provision, I think we're very fortunate in both. We use the BMI at Huddersfield and the Spire at Elland. For that, it is our own surgeons and anaesthetists who are doing that. So we're lifting some of that specific capacity into those private hospitals. So it's not that patients are transferring to non-CHFT clinicians. We're only doing, at the moment, we're only doing cases that we know we can safely do there. We're working with both of those providers and our clinicians around the out of hours model, and we will only use that if we're confident that it meets our safety standards. But we have been working and using the independent sector all the way through the COVID. So we've been using them since March, and I think we're confident in terms of the outcomes that we're getting and the experience that patients have through there. Where we have previously, there were some cases we couldn't do there. That's predominantly because they didn't have the right equipment from a theatre, and we've actually transferring that equipment across so that we can maximise the access for patients of the right procedures. If a patient needs surgery that cannot safely be done in either of those providers, that's why we've made a decision to retain 7 beds on the Huddersfield site so that we can still maintain access for those patients.
Right. Well, I mean, just staying with your original premise, the delivery of any surgery at the hospital will cease, just taking that as read. The question then arises is whether that surgical activity will ever again return to HRI. Will it remain in the private sector, or could it actually be resurrected at Calderdale, for example, and then you'd circumvent your need for any public consultation on reducing beds? You'd have got surgery under the camouflage of COVID.
Okay, so just to be absolutely explicit on that, when the memo says it will cease, it is non-urgent operating that's stopped. urgent operating, whether it's be cancer or for things like vascular, for example, where that's an urgent, but it's not cancer, that's what we've got the provision for. We're continuing to review it on a weekly basis. If our COVID numbers reduce, now non-elective numbers reduce, then actually we would be setting back up again. So we're not saying it's stopped until the end of winter. If we can start that sooner, we will. But our intention is to restart planned operating as soon as we can safely do so.
At HRI?
At both sites. So actually this decision that we've made is not a one site decision, this is a trust decision, so we've stopped it across all of the organisation. And as soon as we can safely start it again, we would do that on both sites.
Right, and taking that on a little bit, and it's hypothetical, but how would you have managed had you not, if your original plans had have gone ahead, if you did not have had the HRI beds, hypothetical I know, how would you have managed without the HRI beds? You know, given the weight of pathology that's confronting you at the moment, would you have managed this in the community?
So we've. Sorry, I'm just in terms of the context of the conversation. If this links to the bed change in terms of the reconfiguration, then we'll still have the same amount of bed. In many ways, we would probably, in a reconfigured organisation, if this pandemic was in 5 years' time, we would have probably been in a position of being able to maintain more planned care because we would have a dedicated green site that we didn't have any non-electives in, and we would use the Calderdale site just for all of the COVID, and we'd be using the Huddersfield site to maintain planned care. It's the issue at the moment that we've got two medium-sized sites and the complexity within there. So longer term, we would be able to manage that more sustainably than we're managing to do at the moment.
So nothing would change. The Huddersfield people, they wouldn't notice. They wouldn't notice that the infirmary had changed.
Well, if it was an experience between then and now, then what they'd experience that we were probably less likely to have to cancel routine operating. So if I use the example, I think at Mid Yorkshire, that they're managing to still keep some of their work going on the Pinterfield, on the Pontefract site, because it doesn't have that non-elective bed base that we've got on both of our two sites.
But where would they be treated if they got COVID? Where would they be treated?
They would be treated.
Sorry. I don't mean to interrupt, Chair, but this was supposed to be about our winter and COVID plans, not about hypothetical questions based on what might have happened had this been when we've done any reconfiguration. And I'm really conscious that we've also got our other providers who need to give their updates as well.
Yeah, in terms of the update, what I said at the beginning, if you can give the overall update and then we will go on to questions, because I'm conscious that, you know, members of the panel will be keen to ask questions and we don't want to run out of time.
No, I appreciate that, but I think that each of the trusts, because the position is changing on a daily, need to give a brief update of actually the position as of today, a bit like Helen did, just for 5 seconds.
Okay. Who is it that you wanted to bring in next then, Vicky?
So I think Jane Close and Karen Stone and Chris Lennox all need to just give you a very quick update on the current
position. It does need to be very quick then.
Yeah,
it does need to be very quick.
Okay, Chair, would you like me to go next?
You can do.
Jane Close, Chief Operating Officer, Ocala. So the position that we are in is that we, as part of our Reformation Restart plans, have our services back up and running. Not all of them at 100% capacity for various reasons to do with distance relation for COVID, length of time of appointments. We have also got some significant pressures caused by staff sickness, and actually we've got a far higher rating of staff sickness in relation to COVID than we did in wave 1. And our district nursing teams are currently operating at upper level 3. So for that, what that means is that we are undertaking our urgent visits only at this moment in time. Again, like Helen, we've got our daily command and control structures in place and the surge and escalation plan. That's my update, thank you.
Okay.
Should I go next, Chair? It's Chris Lennox from Swift.
Yeah.
From Mental Health. Is that okay?
That's fine, yeah.
Well, just very briefly, we're maintaining our partnership approaches across the system, and that underpins everything we're doing, really. We have got pressures in our own acute care, which is not a surprise with levels of distress and acuity for service users. Our occupancy levels are high, and we're working with all the COVID accommodations, but we are managing that at this stage. We're very much focusing with partners on flow through the whole system. So we're looking at how we can work in partnership with obviously social care and our acute partners. We're coping with increased demand for mental health services coming through our single points of access. And we're keeping all community services open and working in a balance between face-to-face and digital solutions. One of the key things we've tried to do is make access as simple as possible at this time. We continue to do that, and we're looking at how our pathways can be as clear as possible and as effective as possible. We have got challenges. We have got obviously our gold, silver and bronze commands in place. We are balancing all those COVID impacts, but we're still moving forward. So I suppose we're trying to work as a good partner and offering our service to obviously our service users and carers at this time. So that's us. Thank you.
Okay. Can I quickly bring in Karen Stone then?
Thank you very much. So hello, I'm Karen Stone. I'm the Medical Director at Mid Yorkshire Hospitals. We, like CHFT, have seen increasing numbers of patients. We're now well over the number we saw at our peak in the first wave of the pandemic. We've now escalated our intensive care and acute respiratory care facilities. We've more than doubled the respiratory ones. We're about to double our intensive care facility. So that gives you some scale of the increase that's required. The number of patients other than those patients in the bed base is also much higher than it was last time. We still have lots of other services running, so we've not got the empty beds like we had first time round. We are starting to reduce activity, so we're concentrating on urgent and emergency cases, cancer, and we are starting to reduce services where that will enable us to put staff into the front line looking after the other patients. So we really don't want to stop any care where stopping it wouldn't release any staff to help us with our acute and emergency work. We've got a lot of things going on to try and maximise the number of staff available, to maximise the number of patients who are in our bed base, who need to be in our bed base rather than don't need to be in our bed base. So we're working quite heavily with partners now to make sure we discharge patients who can be looked after elsewhere. We've got, again, like CHFT, we've had to step up our daily management, so we have daily command meetings now, communications out to staff on a much more regular basis than we had over the summer. So things are starting to feel very different for our staff now in the organisation. It's really much the same as CHFT. I'll leave it to that for time, Councillor.
Okay, thank you for that. Okay, can we move on now and move on to the questions? Dave, you had your hand up. Do you want to go next?
Yes, thank you. I've got 3 questions on the section discharge to assess. So they're arising from the issues raised in that section, but they also relate to some points mentioned in a recent joint Health Watch England and Red Cross report. The first question is to do with the funding of post-discharge care. I think the arrangement has been that the NHS has funded that across both health and social care up until September, but from now on that'll be funded by the NHS for the first 6 weeks only. So it's a question around what kind of problems might arise from that. If I just leave that one and I'll come back to the other 2 questions.
Okay, thank you. Who wants to respond to that?
Chair, would you like me to pick that one up?
You can do if you.
Yes.
Yeah.
So we'd normally anticipate that most people who are discharged from hospital and who need some ongoing care would not need that for a prolonged period of time. So beyond that 6 weeks, that's typically the time sorts of timescales we've provided reablement and kind of rehabilitation support. If someone needed care beyond that period of time, they'd either just become social care funded in the way that people normally would be. They fund themselves if their income or savings were appropriate, or they could apply for NHS continuing care. So, but we think that 6-week period will cover off the vast majority of people, and will then just tip into the normal processes at the end of that. I think it should be fairly straightforward, and we've kind of got some fairly well tested mechanisms for that.
Thank you.
Okay, the second question is about the testing of patients in hospital for COVID prior to them leaving. And the Health England and Red Cross survey found that 30% of people who had been tested hadn't received their results before they had to leave hospital. I just wonder whether that was a problem locally or not, and if so, whether there's action to be taken to try and improve that.
Okay, Richard, do you want to reply to that? Or?
Yeah, I'm happy to, and other colleagues involved in the process will do. No, the new discharge to assess guidance is really clear that people will be both tested and we will have a result prior to discharge. And in fact, we had some local operating arrangements even prior to that new guidance, which would agree both with CHFT and Mid Yorkshire, which effectively put us in that position anyway. So I think the issue is that, with the greater accessibility of testing and the scale of testing, things have moved on quite significantly since that report was first produced.
Thank you.
Thank you. Yes, sorry, third question is about the proposal to have COVID-designated care homes. And I wondered, I think it was a requirement that all local authorities had at least one by the end of October. I just wondered whether that is happening, and if so, what are the implications of that? What kind of problems might be thrown up?
Shall I pick this one up? Yeah. So you're right, there was a requirement that people put forward care homes, which CQC will inspect in due course. In the meantime, before that has happened, existing arrangements continue to operate. So we've obviously had care homes that we've used to support the discharge of individuals who are COVID positive, and those arrangements will continue. In terms of issues that arise from a very direct operational perspective, all residential providers should be operating to really high standards of infection prevention and control. And our own in-house IPC team has been supporting both the council's care homes and the independent sector care homes to achieve that. We've got very good availability of PPE. We're holding quite significant stocks as a council that we're able to support independent sector providers with, and they have good access to PPE through a national portal.
Thank you. Helen, did you want to respond to Dave as well?
Yeah, so it's just to be really transparent in terms of right at the beginning of the COVID with the discharging, the one area when we did the audit that we'd, I'd probably say slightly slipped through the loop was discharges into learning disability homes. So I think we had lots of arrangements in terms of the care of the elderly and those sorts of homes, but less so around the learning disability. So we have closed that loop now, but I just think it's really important that we're transparent around when we audited. We did find that we didn't have that right at the beginning of the process.
Thank you. Councillor Munro?
Hello, yes, my question, it relates to Vicky Dutchborn. You touched on this. You said that the flu vaccination would be optimised. My question just is in relation to flu vaccinations. You've rolled out flu vaccinations to the age 65 and upwards age bracket. I understand that there's a second rollout proposed for the 55 to 64-year-old group, but I just wondered if you could give me some information on that and when that's likely to take place. Thanks.
So at this point, I don't know when it's likely to take place because we've not had the information down from NHS England. We are preparing for the rollout. and we are aware that extra vaccines are being brought into the country from places like America to be able to support us with that. There is a weekly call that I have a member of my team attends with NHS England regarding the flu vaccines and the rollout programme, and they are closely monitoring the uptake on the priority areas before they then release the vaccines for the 50 plus age group.
Okay, that's thank you very much. I just have a second question. It's in relation to access to healthcare. In relation to the e-consult system that some surgeries are adopting. I've tried it myself, and I have to say I found it quite difficult to access. And I just wondered if there's a plan B for people who've been asked to go on the doctor's sites and use e-consult. If there's an alternative plan for people if they can't actually access that, what do they do in those circumstances?
So the processes that we've got in place now for our primary care clinics is that any patient can ring their practice to get have an initial telephone conversation. They will then get a call back from the GP. If they then can't use the e-consult, our practices are offering face-to-face appointments for those patients that genuinely need them.
Okay, all right. Thank you very much for clarifying that. Thank you.
Thank you. Lynn, can I bring you in?
Yes, thank you, Chair. I've got a couple of general questions, and then I've also got some questions for the South West Yorkshire Partnership NHS Foundation Trust representative too, please. So my first question refers to paragraph 1.2 of the report, where it's talking about the 3 key areas, with the first step being prevention and proactive support to enable people to stay well and independent at home. And I just want to ask, as part of that, is there a clear focus on signposting people to community support, which I appreciate at the moment is mainly virtual, community support groups who are perhaps having meetings on Zoom platforms, etc. And whether as part of that there is any support to loan equipment to people if they don't have it at home, as part of early intervention and prevention when we're looking at mental health and emotional well-being to avoid social isolation and loneliness. And where that's not an option, using IT, perhaps signposting to some of the telephone befriending groups in the area. And I just want to make sure, please, that those things are not being lost sight of with everything else that's going on.
So, Chair, do you want me to come in first on this one? So, working with our community, our third sector community services, there has been some areas where we've been able to offer out iPads for people to be able to use so that they can access some of the group calls and the Zoom calls. What we've also been able to do is we've not stepped down any services with our voluntary sector groups, and they have done a lot of work to adapt those so that they can either do it by the Zoom calls or by telephone groups if that works for individuals. We do recognise that from the evaluations of some of this that we've done, that not everybody likes accessing through the digital platforms, and some people have chosen to wait until we could start stepping services back up, and obviously as we came out of the first wave of COVID we did begin to step some services up, and what we have identified across some of those services is that we are doing our best not to step those back down. Because for a group of people they were extremely beneficial and have kept people well. So an example of that is the Mental Health Crisis Cafe. that is now managing to see people in a safe COVID environment, but it does mean that the numbers are reduced, so they are only able to see a few people in that way. But they are one of the groups that have been able to loan out equipment to people. So it is different across different organisations, but as a partnership with the council, where we could, we have loaned equipment and we have bought equipment for them to be able to utilise. It might be worth Chris Lennox coming in on a bit more about the mental health element, because I know Swift have done things with digital and equipment as well.
Yeah, sorry, Chair, it's Chris Lennox. Just very much building on what Vicky said there, we've done a lot of work to reach people and to break down some of those obstacles really to accessing support. We have looked at equipment and we are doing a piece of work around digital inclusion, and we're working with people across the ICS as well in Leeds and Bradford around how we can best do that. As Vicky said, we've had some good success in terms of moving things forward at the same time as dealing with the challenges, and some really positive service user feedback as well about how they've found that of value in different ways of engaging with services. We haven't lost sight of the value of face-to-face and seeing people in safe environments, and that's very much underpinned how we've approached support. So just building on what Vicky said there, really, thank you, Chair.
Thank you. Thank you. Councillor Warner, do you want to come in?
Sorry, Chair, I did have some other questions.
Oh, sorry. All right, okay.
Thank you.
Yeah.
My second general question is just to ask about end of life in terms of proactive signposting to bereavement support, because it's a particularly challenging time at the moment for people who've been bereaved, because the number of options in terms of coping strategies have been significantly reduced, obviously, with the COVID-19 virus. So I'm just wanting to check that wherever life ends, sadly, is there a focus on signposting relatives and friends to sources of bereavement support, please?
So again, Chair, I'll come in first on this, but if any colleagues want to chip in as well. There's been a lot of work done specifically around bereavement support, both at individual provider level, but also at a Kirklees and then at an ICS level. So one of the things that we did do at pace at the beginning of the first outbreak of COVID was procure some new bereavement services and helplines. And this wasn't just for people who were bereaved due to COVID, but it was for people who were bereaved during the period of COVID, because what we recognised is for some people, even if it was an expected death, the fact and the impact of COVID on how many people could be around their loved ones, the restrictions on how many people could attend funerals, cremations, etc., and then people going back and being isolated after a bereavement had a significant impact. So we made it a very broad service specification, and that specification was awarded to a partnership of bereavement services, so they coordinated that amongst themselves. Locally, there's a lot of work being done by Kirkwood Hospice about stepping up their services and making sure that they're publicised and maintained. And the acute trusts have also done a lot of really good and innovative work for people at end of life and who have died, and how they keep people connected. And one of the things that I think the public got behind and was supporting was when CHFT did the hearts that they sent to people who've been bereaved, but also left one with the individual who died, and they were overwhelmed by the response of the public supporting those sorts of initiatives. Again, I don't know if the Trust wants to come in and offer anything additional.
I think you've probably covered everything from our point of view, Vicky.
Thank you, that's very reassuring to hear. Thank you very much for that. And just moving on to my questions for South West Yorkshire Partnership NHS Foundation Trust, please. My first question relates to effective mental health pathways. And I just want to confirm again, because just at the point, I think when Chris was mentioning it, my signal just dipped a little bit, so I missed part of it. I just want to check that now that we've got the new lockdown in place, that the engagement options for people on particularly the enhanced community pathway are still the four that were mentioned before: telephone, video conference, face-to-face, or in clinic. And just as a little add-on to that, I want to check whether if someone is on the enhanced pathway, there is an instruction to staff that they mustn't exclusively stick to telephone contact, whereby it's not always possible to effectively carry out a mental health assessment, and whether or not as well there is an instruction that perhaps face-to-face engagement ought to be taking place at least periodically, and in particular where people are or were shielding and are still extremely vulnerable to the virus, whether that is an option for the engagement face-to-face to take place at home, backed up by appropriate PPE, please.
Yeah, is it okay if I come in there, Chair?
That's fine, yeah, thank
Lynn,
you.
absolutely. We've carried on with our blended approach, and it's in all pathways, but in the enhanced pathway, because that's where you've addressed the issues. Very much, everybody has got an individual risk assessment. Everybody is seen according to their needs. The face-to-face activity is built and built. And we obviously do take appropriate precautions and consider what's in that person's best interest, and to protect our staff at all the time. It's not around an instruction as such, it's around a way of working that is underpinned by the business continuity plans for the teams and the clinical plan for that individual patient. So we're still offering clinic appointments in safe environments, home visits, as you say, telephone contact, digital contact, but indeed people's risk assessments determine how often they're seen. So nothing's changed at all, and nothing will change over the next 4 weeks. Is that okay, Lynn? Have I answered?
Yes, thank you. Yes, that's great, thank you. And when we had our last meeting, there was mention made of a concern from mental health services about what might happen if there were to be an outbreak of the COVID-19 virus on an inpatient psychiatric ward. And so I just wanted to ask whether there is actually now a contingency plan that's being developed. And one hopes sincerely that there won't be such an occurrence, but with the virus rates escalating, it's something that just concerns me, because as well as not being able to admit people onto the ward if there's an outbreak of the virus there, it would be challenging to discharge people home from the point of view of risk to other people if someone is quite unwell, even though they are going home, and perhaps could we rely on them to continue to isolate, etc.?
Yeah, if I may, absolutely. Since April, we've had what we've called a cohorting standard operating procedure, and we're working in accordance with the evidence base and all the requirements around COVID. And we're able to, we have had cases of COVID on wards, and we have been able to manage them safely in accordance with that policy. And sometimes we haven't needed to close a ward because we've got arrangements in place where people can either isolate individually or be cared for in small groups, so that we're able to keep the admissions and the discharges going. On other wards, we have less flexibility with estates, so we've had to be closed to admissions for a short period of time. But that standard operating procedure that was developed at great length really provides full wraparound guidance and a pathway in partnership with other providers as well about how we can look after people who are COVID positive or at risk of being COVID positive. And it does take into account people's individual vulnerabilities as well, Lynn. So that stood us in good stead, and it's in operation now.
Thank you. That's also extremely reassuring. And I've just got one final point, really, rather than a question, Chair, if I may.
Okay.
Just
I can't hear you, Lynn.
Can you hear me now?
Yes, I can.
Okay. Where the report talks about mental health community crisis provision and mental health support generally, and the community options that are available, I just want to suggest that perhaps when we are outlining things like this, it would be useful to include mention of the Calderdale and Kirklees Recovery and Wellbeing College, because I know that they did open in a limited way to have some face-to-face. And so as a recovery college, you know, as someone who was interested in the work of the Recovery College, I just like to make sure that we don't forget to promote the opportunities there as well, please.
Yeah, I'll take that on board. Yeah, and given that we fund it and we've put extra funding into it, you're right, we should promote it.
Thank you, everybody, for your patience with all my questions,
Lynn.
and your responses.
They're very valuable questions. Thank you. Okay, Councillor Warner, can I bring you in?
Thank you. I mean, first of all, I just think innumerable thanks to the phenomenal work that's being done and the pressure everybody's under. But just picking up on some things that have been asked already, but just like clarification. I know a lot of work's been done about to release bed blocking and to try and, you know, find different ways of placing people in care homes or whatever. So I was wondering what the current figure is for people still held up, because in the past I know that there's still been quite, despite all the work that's gone on, it's still a bit, you know, a very big issue. That if 30, 40, 50 beds are being taken that are needed, that is an issue. So the second thing relating to that is the increasing use of the independent sector, both in terms of care homes and hospitals. You know, a worrying thing generally at this period where all resources are having to come together to protect the nation is the rise in use of the private sector and increasing. And I just wondered whether the NHS does get preferential rates when it's using independent care homes. Might be a naive question, but clearly increasing amounts of budget are going to be going out of, you know, into the independent sector. And related to that, I also see that you're recruiting to discharge coordinators, and I'm wondering how that's going. Install to discharge to access coordinators. So, I mean, we're all aware there's a lot of vacancies within the NHS, both in terms of nursing staff and doctors, and of course care staff. So I just wondered how morale is and how everybody's coping with such pressures and being short-staffed. Thank you.
Thank you.
I think
Karen.
Yeah, Helen and Karen need to answer that one.
So in terms of how are people coping, I think we need to accept that there's a different people are entering wave 2 in terms of the second wave of COVID and winter in a different place than they were wave 1. People are tired, people know what's coming, and there's an added anxiety that goes with that. We've invested a lot of time into staff wellbeing. So we've still got things like we've got wobble rooms, so if people just need 10 minutes to go off, and then it's stocked with music and biscuits and sweet and all sorts of nice messaging, etc. We have made a decision this time that we're not going to restrict any annual leave, because we're actually promoting people to make sure that they do get their annual leave, and we have implemented a process where we're asking every member of staff to have an hour a week wellbeing. They can go off and do what they want in that. But actually, we think if we invest in staff's well-being, then actually they'll they'll be a bit more resilient. I think I'd
Is
also.
that paid time, Helen?
Sorry?
Is that paid time?
It is. It is. And we're not being prescriptive around what you use, because everybody's need in terms of well-being is different. It might be an hour on an exercise bike, it might be a walk, it might just sitting and reading or meditating. So we're trying to be quite open in terms of how we do that. I probably want to put a shout out for leadership as well. I think our frontline staff are absolutely critical, but we've also got a group of leaders, our matrons, senior doctors, operational managers who've gone from winter planning last year to winter to COVID planning, and there's just been no respite for them. And I think it's as important that we make sure our leadership are well looked after as we go through that. On this very specific question in terms of the transfer of care, we've got 38 in Calderdale and Huddersfield. From a Kirklees perspective, that is lower than it was. So as I say, that work that teams have been doing together, it's paying dividends. It's not particularly going back up, and I think we've just got to, as a system, get to a realistic number. There'll always be patients going on as quickly as we're taking them off, so you're never going to get to a zero position. I think it's probably important for us to recognise.
Thank you. Karen, do you want to come in?
Yes, thank you. Our staff are extremely challenged this time round. There's no doubt about it. Clinically, they know what's coming. It's coming at them fast. We've done an incredible amount of work around wellbeing over the first wave and through the summer, supporting staff, making sure people have had a break, making sure that we've got a lot of psychological support, and we've invested in a lot more psychological support that's available exclusively for staff. But we know that even doing all of that, there are still people suffering from PTSD from the first wave. There are people in whom that will not yet have shown and will start to show as the pressure ramps up this winter. We've got the second issue of staff availability that makes resilience hard, in that if people are becoming ill or they become a contact through test, trace and isolate, that then puts even more pressure on the team back at base, because there's less people to deploy. So it is really hard. And Helen's point about leadership is key. We're promoting kind and compassionate leadership in the organisation, because that's what people need. They need to feel listened to, and we're trying to do what we can to ensure that people do feel listened to as our staff, and all of that will help us get through our next wave. But it is going to be a much harder challenge from a staff point of view than it was last time round. Last time round was very much new, novel. There were, of course, people who were concerned and anxious about what was going to happen, but there was a bit of this is new, it's an incident, we need to get on with it, let's do what we can, and there was a lot of energy. That energy is not as high this time, and so the challenge for us in the senior leadership teams is to keep our staff well informed, safe. We've got plenty of PPE, we've got the flu vaccine for them, and we will get them vaccinated as soon as we can with COVID vaccine to help them feel safe, and the other psychological stuff around that for staff safety. So it's a big ask this time round, is how I would describe it. So thank you for asking the question, but you can be assured that we're absolutely on doing the most we can to keep our staff healthy and well, so they can keep our patients healthy and well.
Thank you. Can I just ask, have you heard whether or not the likelihood of tests being available for all staff? Because obviously we know that you have a certain number of staff off at any one time because they've either been in contact or waiting for the results of a test. And it was suggested by the former health secretary on Radio 4 yesterday morning that in their what's real and what's fantasy, all staff should be entitled to get tests as and when instantly.
Leslie, that can come part of the next
oh, so it does. Okay,
yes.
sorry.
Yeah, it does. Can I just bring Peter back in. Peter, you wanting to ask a question?
Thank you. Just one last thing, Chair, if I may, and that this is really about hospital avoidance, and it may be one for Locala. I don't know. I mean, we do realise that everybody in hospital is there for a reason, but it raises the question, given the pressures on hospital services, whether we should be doing more in terms of hospital avoidance. And I just wondered, from the Locala general practice point of view, I just wondered what the plans were there. And I realise Vicky Dutchburn doesn't like lateral thinking, but I just wondered how equipped the community services were in Greater Huddersfield to cope if the infirmary was suddenly overwhelmed.
Shall I go first from the Locala point of view, Vicky? Okay, so from our point of view, we have got our short-term rapid response service that's in place, and what we did in wave one was support that through some redeployed colleagues as well. We haven't taken that step at the moment because at the moment we are coping with our 0 to 2 hour response, and we are working in partnership with GP practices. So to answer the question about the lateral thinking, we are doing that piece of work to make sure that we spread the resource, because we absolutely agree and accept that the way to support CHFT from an acute point of view is to stop those people that don't need to come into hospital in the first place. And that is to work as well in partnership with Kirklees Council. So actually what we do is pick that patient, make sure that they're safe to be managed at home, and we wrap the care around them.
Are you actually measuring bed days saved?
It's really difficult to do. What we're doing is putting in a dashboard that will be reported through A&E Delivery Board that talks about the numbers of responses that we've done in terms of visits to patients and whether or not they're still at home 48 and 72 hours later.
Thank you.
Thank you. Could I bring Councillor Liz Smage in, and after Liz, if we can move on to the next item, which is around COVID-19. Liz?
Yes, thank you. My question was about capacity. You said you're operating at a 95% capacity or thereabouts at the moment in the hospitals. So what capacity levels would need to be reached before people were transferred, and I'm presuming they would be transferred to the Nightingale Hospital? What level of capacity needs to be reached before that happens, and do we know that what protocols would be in place for that? And I'd also like to ask as well about discussions with primary care. What discussions are there being held with primary care in order to help with capacity within the hospitals? Thank you.
Thank you, Liz.
So does Helen want to take the the Nightingale question? And I'm happy to pick up about the primary care, Helen.
I can, and Karen may well wanted to say something about the Nightingale. So what I can say in terms of the Nightingale, it's probably best to start it that way around. We're in active conversations across West Yorkshire at the moment. So I know the medical directors met yesterday, and the chief operating officers and chief nurses are meeting tomorrow, just to understand what's the optimal use of the Nightingale, because recognising that there's a bed capacity challenge and there is a staffing challenge. So I know from a CHFT perspective, I could, in theory, open another cohort of beds. What I don't have is a staffing model to be able to staff them, but the physical beds are there. So if we do move into the Nightingale, it's still got to be staffed. And so at the moment, we're just having some conversations around it. Is set up with a set of principles and protocols and operating procedures for it to be a critical care facility. But we're having some conversations in wave 2 and in winter. Is that what we want to use it for? So I think I can't give you an answer on the trigger and when will we. What I can say is it's an active conversation, again, led by operational colleagues and senior clinical colleagues around how do we make this work best for West Yorkshire, because I think the position that we're in, and I know Karen's described in Yorkshire, is replicated across all of the trusts in West Yorkshire. And we are now, I think you might have seen some of the press, we're now as a system, from a West Yorkshire perspective, higher on inpatient COVID activity than we were in wave 1.
Thank you. Thank you for that. That's been a very good discussion around winter pressures. We'll now move on to the item 8 in item 7, which is the COVID update. And can I thank the officers for the presentation on the winter pressures, and move on to the next item. We have Jane O'Donnell, Head of Public Protection, and Emily Parry-Harris, Head of Public Health from Kirklees Council, to present on this report.
Hello everybody. It's
Hi.
nice to see you all. I hope you're all keeping well. Richard, can you share the slides for me, please?
Just get to them now.
Jane and I are going to undertake a double act for you today. So we'll start going through the slides. We're going to take you through some high-level data, a little bit of an update around the testing situation, and then Jane is going to talk you through some specific issues around the care homes.
It should be on the screen now.
It is, yes, thank you. Can everybody else see that? I can only see councillors. Oh no, I can't see councillor Zaman anymore. I'm going to get you to nod for me. Thank you. Okay, so I think you'll probably remember that last time I came to talk to you, we talked a little bit about how quickly the data is changing. And the data that I'm showing you here was correct up to the 22nd of October. I would suggest that next time I come to Scrutiny, I don't send you data slides in advance, but that I bring you a presentation on the day and I talk you through the data as it is on the day that I come to Scrutiny, because the situation is changing so very rapidly. But if we take the data that we have in front of us today, as of the 22nd of October 2020, we'd had 8,227 confirmed cases of COVID in Kirklees, and you'll see that 1,120 of those cases were within the last week. So a very, very rapid increase in terms of the daily numbers, weekly numbers, sorry. Next slide, please, Richard. Okay, and again, this is all feeling slightly out of date now. So a couple of weeks ago, this is the West Yorkshire position. So it's probably a little bit small for you, but you'll see that the green line was the England numbers, and the blue line that's highlighted was the Kirklees position. So a couple of weeks ago, things were looking in like this across West Yorkshire, and Kirklees was looking relatively positive in terms of its position in the West Yorkshire figures. That's changed. We are now, the Leeds rate has continued to come down. Bradford is now the highest, and Kirklees is second highest. So again, a really good example of how quickly the data is changing. Next slide, please. Okay, so I'm sure Jane is going to interject here as well. Just to give a very brief update on the position around testing. The testing split into three sections. We've got the mobile testing units, we have the local testing sites, and we have asymptomatic testing. So the mobile testing sites continue to be based at Batley, Dewsbury, Holmfirth and Fartown. These mobile testing units are deployed at the behest of the Director of Public Health. So if we see a significant increase in cases in a particular locality, Rachel can ask for a new mobile testing unit to be set up, and we are receiving weekly data on the use of these sites. The local testing sites are currently walk up by appointment only. Their current locations are at Dewsbury, Huddersfield and Shaw Cross. and looking for additional sites as detailed there. And then in terms of the asymptomatic testing, the national testing programme continues to be experiencing very high demand. So the asymptomatic testing is currently paused, although I believe the intention is for the asymptomatic testing to begin towards the end of this month. I think some of the pressures that have been being experienced in the testing programme still exist, but are reducing slightly. I can comment on my own personal experience. You'll all be very pleased to know that I don't have COVID, I just have a grotty cold and I'm not very well. But I had a COVID test. I sent off for it on Tuesday. I received it on Wednesday and I got my results via text message this morning. So that part of the system is working much better than it was previously. Jane, is there anything that you wanted to add?
I would just say with the local testing sites, I've contacted the regional coordinator for the Department of Health and Social Care to see when we can have the local testing sites as walk-ups again, because obviously we are aware that for those local residents, that was the idea of having these walk-up sites. I've been told presently they can be used as walk-up sites, but we haven't to promote it widely because of the impact this could have on the capacity of the Lighthouse labs. We are at the moment, as regards the site for Dewsbury, in discussion with Deloitte and Sunbelt, who do the site surveys, for obviously taking that forward. But we are aware that at the moment there is a lot of capacity in the system for the built for local testing sites. And we're still looking for a site in Edmund-White because of the specification, what is required for local testing sites. A number of areas that we've looked at, and obviously I've had those conversations with the local councillors for their views on those sites. Some of them weren't appropriate. So we continue to look for another site in Edmund-White. What we've also been told is that the local testing sites, we're trying to make them more winter-proof, so work will be done on them, because at the moment they're quite sort of a little bit like a tent structure, so they're going to try and make them more of a solid site so that they're more appropriate for inclement weather. So that work will be happening shortly. As regards the asymptomatic testing, and I heard one of the councillors, sorry I didn't catch the name, asking about asymptomatic testing for healthcare staff. That is something what is in discussion about, and I'm on a West Yorkshire and Harrogate meeting after this, where we'll hopefully find out further detail about whether that is to be taken forward. As part of asymptomatic testing, that does include whole care home testing, which we know continues to happen, and obviously that is detailed in the following slides as well.
Lovely, thank you, Jane. Next slide, please, Richard. Okay, so just a little bit more detail here around the testing scenario. So you'll be aware that there was some additional testing being undertaken in extra care and supported living, and Jane and her team have been doing a heroic job, I think we should describe it as, of supporting the care homes in their continued response to COVID-19. It's been a busy few weeks for you, hasn't it, Jane?
It has, and obviously, as it says on the slide about testing in extra care and supported living, we've submitted all the facilities what meet the CQC definition. They've gone in. We're now waiting for further information about when this testing will be rolled out, so that we can provide that information. That testing will be for residents and staff within those extra care and supported living facilities. We're informed at the moment that this will be one-off testing and then be reviewed to see whether it becomes part of routine testing. As regards care homes, From the previous update, what Emily provided, we've had a further 13 care homes what have had an outbreak of COVID-19. 10 of those had a previous outbreak. If you remember, on the previous slides, what Emily showed in the scrutiny panel, I think it was in September, Emily, at that time from March to September, the team had supported 66 care homes. So we're again seeing a steady increase with the second wave of care homes experience a care home outbreak. New national guidance now is not to retest for 90 days when a staff or resident tests positive. That is because of residual virus within the respiratory tract. That does not mean that anyone remains infectious as long as they don't have a high temperature. So we don't retest unless someone actually starts with symptoms of COVID again. The team has started to do a number of audits and outbreak walkabouts in care homes to do that support. Richard, could I have the next slide, please? Obviously, I just wanted to give you a little bit more detail of the work what the IPC team do. Obviously, as part of outbreak response, we'll look at the gathering of data, looking at number of residents within the care home, staff, that includes all the ancillary staff as well, to see a picture of admissions from the outbreak, and obviously if there's been, unfortunately, if there's been deaths. The team has an excellent relationship with care homes. Care homes tend to come to the IPC team before the reporting to Public Health England, but obviously we then ensure that they escalate that up to Public Health England, and then obviously we provide that support during the provision of the outbreak. The outbreak is concluded 28 days after the last positive case, so it's a lengthy period of support from the IPC team to the care home. We obviously provide guidance. We can do that direct to the care homes, and we also use the NHS platform as well to ensure information is sent out to care homes. As I said earlier, obviously the weekly testing of staff and monthly testing of residents continues for whole care home testing. If positives are found, then we use Pillar 1 testing for care homes. And obviously, once you start with seeing an outbreak, with Pillar 1, you tend to see an increase in cases as well. Next slide, please, Richard. So obviously as well, you're aware that care homes have received funding from the National Infection Control Funds. So obviously we've had discussions and worked very closely with colleagues within adult social care, looking at how that funding is used. We've also, the team have delivered virtual and face-to-face training with care homes as part of the PPE training initiative, because it's extremely important that staff know how to don and doff correctly so that they don't transmit the virus to themselves, and safe use of wearing the PPE for the correct amount of time. We've ensured that the care homes have access to emergency supplies of PPE when required, if they weren't able to access it from their normal supplies. And as I say, we've worked extremely collaborative with CCG colleagues, CQC, and obviously Kirklees contracting team, adult social care, Locala, primary care and acute trust. So it's been very much a whole systems approach in care home provision. Thank you.
Next slide, please, Richard. Oh.
That's it.
That's it.
I think that's finished, Emily.
It was. Sorry, I'd forgotten that Jane had tweaked the end of the presentation. So as I say, the situation is changing very, very rapidly in Kirklees. A few things that are really important that we remember. One, that the effects of the national lockdown will not be felt for a couple of weeks, because the people who already have COVID and are going to become very poorly from COVID already have it. So the full effects of the lockdown will take a couple of weeks to show themselves in the system. Very positively, we had started to see a slight decrease in the cases of COVID that have been experienced in our population. So hopeful that continued decrease will show itself in the data as we move forward. The 6 key messages, and last time I came to talk to you all, I asked that you take all the opportunities you can to continue to share those messages, remain incredibly important. Hand washing, social distancing, being tested if you're symptomatic, limiting your social contact, the use of face coverings, and isolating if you are symptomatic are incredibly important. And they work in terms of preventing the spread of this virus. The virus doesn't move around by itself. The virus needs people to move it. So the more that people stay at home, the better. Obviously, we are very early into this second period of national lockdown, and we've got another 28 days to go. We're at the beginning of it. I think it is incredibly important that we recognise that the work that our colleagues I've already talked about how hard the infection prevention control team and the nurses have been working. I think it's incredibly important that we recognise how hard those people who've been involved in the community response to COVID-19 have been working as well, and that because of their work, we've seen a significant reduction in the number of cases that we could have otherwise seen. The numbers are still too high, and we need to bring those numbers down. But it could have been so much worse. And I think I would like to take the opportunity to say thank you to all of those people. And I don't want to put words in your mouths, councillors, but I'm sure you would want to say. And that was all that I was going to say today. I think you've had a really rich discussion with the acute trusts, and obviously the very, very significant pressure in the system is with them at the moment.
Thank you both, Emily and Jane, for that presentation.
I'm also really sorry, Councillor Zaman, I need to leave at 3:30.
Yes, I'm aware of that. Yeah. Thank you. Well, very quickly, Emily, we'll move on to the questions from the panel members, and Peter already has his hand up.
I can always rely on Peter to get his hand up quick.
Quickly get in there. Right, Peter. You're on mute, Peter.
Well, you do need to unmute your microphone, Peter.
Apologies. Good job you didn't hear what I said, Emily.
But I can lip read.
I ask you this every time, but as a percentage of people who are known to be positive in Kirklees, what percentage of them who are positive are actually being traced? Because we know that the optimum is 80%. We know that the popular press is telling us it could be as low as 20 nationally. Yep. And I wondered what the trace rate is in our particular patch, please.
I think Jane is probably better placed to answer that question, and I'm sure she'll have the data in her head, I'm sure. But it's not the people who are positive who need to be traced; it's their contacts. It's the tracing of their contacts. But
sorry,
Jane,
that's what I meant. Sorry, that's what I meant.
Yeah.
Jane.
Yeah, we're running about 59% at the moment, but we are actually looking to launch our local contact tracing service in November, which means that individuals who are not contacted by Tier 2 within 24 hours will come to a local team to be contacted using a local number. So hopefully we will see an increase in the numbers or are contacted, the positive cases contacted, for us to take their contacts to ensure that they're isolating. And if they're isolating, that they don't need any support to continue that isolation, because we know that some people need support with food provision, with medication. So obviously we want to do more of an holistic approach.
Jane, is there any evidence that this more local contact is actually proving more effective? Because again, there's speculation about whether being phoned from somebody in Hemel Hempstead really means anything to you, whereas if you get a telephone call from somebody in Kirkeaton or wherever, it means a lot more to you.
Yeah. Speaking to colleagues who have launched it in their local area, they say that the percentage uptake has definitely improved. I've spoken to colleagues within Calderdale. I've been in contact with people in Sandwell, and it has definitely seen a better uptake by local contact tracers.
Thank you very much. Thank you, Chair.
Thank you. Can I ask Dave to come in now? Dave Rigby?
Yes, my question really follows on from Peter's. In your report, you've covered the incidents and the testing, but it'd be useful to have a section just that looks at tracing and isolating. So we just got onto that. First question is are you now getting sufficient real-time patient identifiable information from Public Health England to enable you to do the tracing locally? And secondly, are you actually able to follow up in terms of supporting people who are in isolation? I know you just touched on that, but I just wonder what specific services you're able to provide there. Thank you.
Yeah. Our local service, as I said, obviously to Peter, will be launched in hopefully around about the 18th. We have to agree. There's lots of things that we have to do to actually launch our local contact tracing service with the national PHE team. So we have weekly meetings with them to make sure that we've met all the criteria. There's GDPR to go through. We're at our final, hopefully final couple of weeks on taking this through. The information what we will receive will come through what we call Power BI, which shows the individuals what haven't been contacted by the national tier 2 tracing system. That will come through on a daily basis. We're told that it'll come through on a set time around about 10 o'clock on a morning, which gives us time to then ensure that we can check if there were individuals what were previously known to us as being vulnerable, so that we can prioritise those individuals to be contacted first. Because what we're really aware of, as you say, is I'll be honest, if I see an 03 number, I tend to ignore them. You know, cold call numbers, I call them. So whereas if I see a local number, then obviously I answer my telephone. We also want to look, once we've got that established, my aim is then, following discussions with Rachel Spencer-Henshaw, our Director of Public Health, is to look at a home visiting service for those individuals who do not answer to the local contact tracers, that we actually go knock on the door and see, you know, obviously try and see why they've not been made that contact. It may be that they feel that somebody's been ringing them too many times and they're just fed up of the phone ringing, you know, so actually somebody knocking on the door, having that conversation with them. If they're not in, it may be that they've actually been hospitalised. There may be valid reasons why that individual's not in. There may be, as I say, too ill to answer the phone, or, as I say, hospitalised. So we're actually we're looking to then go and do what we call a door knocking service for those individuals who don't respond.
Thank you, Jane. Do you have a follow-up?
Well, it was just in terms of specific services to help people who have to isolate. Are there specific services you can provide or others can provide?
We'll obviously link into the community response for that, Dave.
The community response that's being managed through Jill Greenfield and her team has remained in place through the whole of the COVID pandemic thus far, and is still available to offer support for people, particularly around their social needs, and supporting them to make sure they have access to food and pharmacy.
And is that service, is there a good level of awareness of that service?
I think, well, they're getting a lot of phone calls, so yes.
Thank you.
Thank you. Can I bring Councillor Munro in?
Yes, thank you. My question is also about the test and trace, in actual fact, because I want to know if when people go for their tests, are they being reminded that they must upload the results onto the app on the phone? Is that something that's being, you know, because I've heard about a lot of people who haven't actually downloaded the app because they don't want their information sharing with the company that's provided the NHS app, and So I just wondered, are people, being reminded when they go for these tests that they must upload the results onto the app as soon as they come through, so that it makes it easier for people to be contacted? Is that something that's being done? Do you know?
As regards how the results are given, you can actually receive your results via an email or a text. Obviously, we want to ensure that people, as many people download the NHS app as possible.
Yeah.
But, again, it's personal choice. We've tried to get it over that information isn't shared. That is about phones being close to one another. If you're looking at contact tracing with using your NHS app, but that should be given when they actually apply for the test, of how they will receive their result. As I say, but what we have to remember is some people's phones are not compatible with the NHS app. Some of the older phones aren't. That's why you can still get your result via email or a text.
Right, and so when people so obviously they can't upload the result if they don't have the app. So I mean, that has implications for the for being for contacting their contacts. So I guess, is there anything in place for that?
Yeah. What happens is if somebody receives a positive result, then what should happen is once you receive your positive result, you can actually either go online and fill in the form where you can upload your contacts.
Yeah.
Or if you don't do that within a specified period of time, you should receive a phone call, and this is from the actual NHS test and trace, whether that's a tier 3 or a tier 2 representative, for you to then put your contacts in.
Oh, good. Thank you. That's reassuring, because I just wondered, I wonder if people are being, do know that they have to upload this information. Okay, that's great. Thank you very much.
Thank you. Thank you. Very quickly, Councillor Warner, do you want to ask your question? I'm conscious Emily needs to leave.
Yeah, thank you. The first question I wanted to ask was something that's growing in popularity nationally, and there's a fairly active small group on Facebook. This business about not being able to go into a care home and make contact with your loved one. And clearly there is some attempt nationally to look at some possible solutions. I wondered if there's any conversations going on with any care homes about creating a way of having tests immediately and then being able to go into a discrete area or something.
New national guidance came out yesterday about care home visiting, and one of the things is that we can look to do indoor visiting, but obviously risk assessments have to be undertaken. We've got to ensure that there's the correct environment, but obviously the IPC team will work with care homes, and obviously there's other ways to communicate still. Some people may still want to use, there's the iPad, for different technologies, what we can use. But yesterday, yes, new guidance came out where individuals potentially can then go and visit their loved ones within the care home.
Yeah, I mean, it's the heartwarming stories, isn't it, of the 95-year-old who hasn't had touch of her family for 6 months, etc. Which also brings me on to the question I was trying to ask before as well, is to do with, again, myth and reality with the government and what it's like for you guys on the shop floor, to do with testing. The former health secretary, Radio 4 yesterday, is talking about the possibility of tests being available for NHS staff and care home staff almost on a daily basis. Now, my guess is we're quite a long way from that. But is that something you hear direct fed from London, or?
Not as regards daily testing, no. We have weekly testing for care home staff. That is already happening.
Yeah.
And there's been very successful, since its implementation.
Yeah.
As regards other healthcare, as I say, these discussions ongoing, and I'm not sure whether we've still got our acute trust colleagues on the call to see whether they've heard anything additional to that. As I say, I'm next on the West Yorkshire and Harrogate testing meeting, where I'm sure testing is always discussed, and I'm sure we will be discussing that as well.
Okay,
but
thank
not
you.
not on a daily basis. That's what I've not heard anything about testing on a daily basis.
On me. I'm
Thank
very
you,
sorry,
Elizabeth.
Councillor Zaman. I am going to have to go. I'll leave you with Jane, and if there's anything you want me to pick up, just let Richard know.
We will do. We will do. And
Really
thank you for attending,
sorry.
Emily. Thank you.
Bye, everybody.
Bye. Lynn, do you want to ask your question?
Yes, thank you, Chair. It's just about unpaid carers, really. And in the interests of supporting them in their role, I do know of instances where people have been challenged early on in the previous lockdown about why they were travelling or visiting people. And I just wondered whether there was any scope for unpaid carers to have some kind of authenticity documentation provided. And I know that South West Yorkshire Partnership NHS Foundation Trust, one of the carer support officers who works out of Pathways in Murfield did provide a letter whereby she could be contacted if any carers of people who were being supported by mental health services had difficulty with travelling and visiting the people they care for. And so that's still an option with regard to that. But I'm just thinking more about carers generally, where there isn't a mental health focus. I think something like that would be very useful, even if you never have to produce it. It's just knowing you've got it.
Thank you, Lynn. Richard, are you wanting to reply to Lynn, or are you wanting to ask
I
a
can
question?
do. I can reply, Chair.
Okay,
so
thank
the
you.
ICS did, in wave one or the first lockdown, lead some work around working with the carers organisations more generally to provide that sort of identification. I think it's clear, though, from the latest set of regulations that there's much more recognition of the need to be able to continue to provide support to people who are vulnerable, both through recognising the role of carers, but also in terms of some latitude in terms of things like respite care services to support carers that previously were closed. So I wouldn't anticipate that people would particularly face a challenge this time round. As I say, I think the regulations much more recognise the role of carers and people providing care.
I suppose it might be a case of just watching the space and perhaps checking in maybe with the groups like the Kirklees Carers Count team, just to make sure that they're not being made aware of any difficulties.
Absolutely, and we've got a very good relationship, with the carers organisations in Kirklees, so we can do that.
Thank you.
You're on mute, Councillor Zaman.
Sorry. I was asking Councillor Smage, is there anything that you would like to add or comment on?
Oh, no, thanks. I think that's been very thorough. Thank you.
Okay, thank you. Thank you for that. If we can wrap up on this item, and I'd like to thank the officers for attending and giving us detailed information on winter pressures and COVID. And if you would like to leave, and then we can move on to the next item.
Yeah, I'm quite willing to come back next time, Councillor Zeman, and give an update on the local contact tracing if they find that useful.
Yeah, definitely. We'll call back on you.
Thank you.
Okay, thank you.
Thank you.
The next item is the Kirklees Safeguarding Adults Board 2019 and 2020. And if I could ask Mike Evans to report on that, please.
Yes, Councillor Salmon, can you hear me okay?
Yes.
All right, that's good. Because I'm quite a long way away from you at the moment. So.
Oh, thank you.
Okay. We bring this to you every year, and just for the benefit of members, we produce an annual report each year. The annual report looks back over progress during that year and the issues that arose. We also have a strategic plan which is a rolling 3-year plan. And of course, the annual report produces a lot of the intelligence we need to update the rolling plan. So that's the way we've worked now for a number of years quite successfully. And indeed, when we had the peer review, they recognised that as an excellent way of working and gave us quite a lot of praise for the way we do that work. The Safeguarding Adults Board is a strategic partnership. It's hosted by the local authority, but it actually has a responsibility to be arm's length from the agencies that are involved. The 3 statutory agencies are the NHS, police and local authority, but we have a wider representation on the board as well to make it effective. So we're asking you to receive the annual report this year, and of course, to use a cliche that's around at the moment, we're living in exceptional times, and so I probably would like to, well, I would like to use this opportunity to update you on how the board is operating for this year, because it's important we are effective in fulfilling our responsibilities to, in a way, using the words that apply to your job, provide some scrutiny and oversight on how the partnership is being effective in managing safeguarding issues during this period as well. So I'd like to talk to you a little bit about that as well. But first of all, are there any particular issues or questions members would like to raise about the annual report for last year?
Dave, do you want to ask your question? Dave, you're muted.
Apologies. Yes, I just wanted to ask a question. The section on our key priorities and achievements, it's quite a lengthy section. I'm just wondering whether it might be useful to have an overview of key issues that arose in the year, a kind of summary page and a half. So that would kind of highlight the key issues as you saw them.
Yes, we could certainly do that. I think the most important thing that we do in that section, and one of the reasons it is quite lengthy, is it's not good enough to just say what we think we've achieved. We've got to say what we want to do next. So you'll notice on each of those sections, the most important bit to read is "and next," because that actually is what would sit in that document you've just talked about, and that would be the main areas that we feel we need to focus on based on the experience of that year. But I accept there's lots we could do to make this more accessible.
And thank you. I note that you're going to be saying something about the current year.
Yes.
So the other question I had was, and you maybe come on to that, is in relation to deprivation of liberty safeguards.
Yes.
Were there any particular issues that have cropped up in relation to COVID restrictions?
Right. It's not that we're wholly aware of at the moment, but it will be covered in what I want to say next, if that's okay. 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 Any further questions on the report itself?
No.
Shall I move on?
You can move on, yes.
Okay. All right. So just to say that at the beginning of the year, as it became apparent that the board really had to step up to the mark and be part of the team in terms of playing an important part in Kirklees in helping to keep people safe, it would not be good enough for us to just rely on our infrastructure initially and just say we have a board meeting every 3 months and we have subgroups that do some work for us. We had to be a little more proactive than that. So we decided to develop a risk register. And it's been an iterative process, the risk register. We've developed it throughout this year. And we've had a core group of the key partners that's representing the CCGs, the local authority, and the police, where I've met with them every month, and we've developed a risk register. And more recently, we've now, as we've learned through the pandemic, where the areas for deeper inquiry or audit or a deep dive into we should look at, particularly as we come out of this period. Now, we have a subgroup called the Quality and Assurance subgroup. We're very fortunate in Kirklees that, and I think I've been listening to the meeting today, and I think it's exhibited it here. Partnerships in Kirklees are as strong as I've seen anywhere. They're very good. The partnership between the local authority, the NHS and the police is very, very strong. And that's a benefit to Kirklees, and we see it in our board. Attendance and membership of the board is very strong, and people contribute, and they recognise their role is to be part of the challenge as well as just representing their organisations. The main areas that have come out for us are, if I tell you to start with, the work plan for this year was primarily going to focus on 3 specific areas. We will never take the eye off the ball of making safeguarding personal, and that links very closely with mental capacity assessment as well, as I'm sure you understand. And another area we had identified as an area to continue to ask our quality and performance subgroup to focus on and look specifically at any issues that came out of safeguarding adults reviews and any file audits was mental capacity assessment. And that's, as you say, is as important during this period for all sorts of additional reasons as it was before. And the third area, which came really out of the peer challenge that we had, we've entitled Ensuring Effective Practice. And that's, there was one thing we asked the peer review team to have a look at is all the work we're doing at board level, where we pat ourselves on the back and say we've developed some new ways of dealing with this, that or the other, whether it's a self-neglect policy, whether it's about dignity and care, those kind of areas. How effective is that on the front line? The golden thread that goes through from a strategy, which is the board is a strategic board, through to frontline practice. And so we want to know how successful the initiative we put into place, which are practitioner forums, where the board itself and the safeguarding unit provide quite a lot of input to practitioner forums, and I've attended some of those as the chair, and I think they've been very helpful and very useful. So what else do we need to do? Well, if we look at what came out of the risk register, and I've got the most recent copy of it here, the main areas that partners are telling us, and I must mention Healthwatch here, because Healthwatch have been fantastically helpful. Since they joined the board, it's been a real bonus, because what they do is give us real life stories. So as well as looking at numbers on a sheet of paper, we can hear about real life experiences much more effectively than we could in the past. The areas that we're picking up through discussion with Healthwatch, but also looking at what the partners are telling us at the board, is the impact of social isolation. Linked to that, impact on mental health and mental well-being. I mean, you could have told me all these, but this is clearly where we're going. Any specific consequences from shielding that we need to think about. I think a very important issue is the impact of not seeking or accessing main NHS or services or social care support, and any exploitation of vulnerable adults that maybe is not being seen at the moment. The doorstep crime stuff is one example of that. And one other area, which is not a risk, but any identified benefits from the way in which people have found themselves working with vulnerable adults during this period that would be worth keeping. So we want to hear about that as well. So those are the areas that the board will be working on from now forward. Okay.
Thank you for that, Mike. Thank you. If we can open it up to the panel for questions, either to Mike or Richard. Peter?
Thank you, Chair. Mike, I just wondered, you've given us lots of important information about how you're performing and how things are working in relation to this epidemic. I just wondered what your stance was on these very, very difficult positions where, we've been asked earlier on to cite anecdotes, and I realise that personal experience is usually very atypical. But I heard of some family recently who were told that their mum was going to be discharged from the local hospital, Huddersfield Royal Infirmary, to a care home where they knew full well there had been an epidemic. Now, I really don't know the details, but and there was active disease in the home. Now, so they don't know the ins and outs. But when you're faced with these ethical dilemmas, what is the safeguarding stance on that, please?
Well, from a safeguarding board's point of view, if that came to us, we'd want to ask the question about what safeguards were in place to allow that to happen. It can happen. We heard earlier on, it was quite useful to listen to the public health presentation about care homes because, and I know from my own experience, not every care home's the same. And some care homes will be able to offer better protection than others. Indeed. So, with that story, I can't answer the question, but to say you're quite right to raise it, and the family are quite right to ask the question. If that's being proposed and planned, what reassurances can you give us that this is a safe course of action at this time? And of course, the other issue, and it's always a balance, and throughout my career, and Richard will know this, it's always a balance. Hospitals are not safe places either.
No.
So you've always got to work out. There's probably not a risk-free option with discharges. But there is best practice, and the NICE gold standard gets on best practice for hospital discharge is the best thing I know for approaching this issue, recognising there are risks, but recognising there are things you can do to manage and mitigate those.
Thank you. Thank you.
You've gone quiet. You're on mute.
Well, sorry. Well, if there's no further questions, I'd like to thank Richard and Mike for attending the panel.
Sorry. I think Councillor Warner has her hand up.
Yeah. Councillor Warner, yes. Yes, Councillor Warner.
Yes, sorry. This is just, again, partly anecdotal, but in most communities, and we have one or two in Slough, where I live, and you've only got to walk into Huddersfield, there are clearly individuals with varied needs, including one suspects some mental health needs, who seem from the outset to be unreachable, and yet at the same time, they're potentially a source of risk for many people. They're the ones who go in shop, won't wear a mask, talk to people, etc. Now, is there any sort of outreach goes on in that respect, or do people contact you and, register of people to be concerned about?
We don't hold a register of anybody at the board level.
Okay.
Individual agencies are aware of vulnerable adults who may be at risk to themselves or others. If they're not known, it's not until they are known that anyone really do anything. It could be that if you're talking about people who have recognised mental health needs, that they are known. I don't know about you, but my experience of people who are quite blasé about protecting others is they tend to be people who are not necessarily are vulnerable themselves or have mental needs. They tend to be asymptomatic people who think it doesn't affect me. But it's a complex issue, and
Sure.
indeed, a lot of this will be our learning and understanding about this will only come over time as we come out of the pandemic for many of these things. But you raise a very important issue about how much agencies in Kirklees can do to, and the voluntary sector can do to influence people to behave well.
We have a vulnerable person in the village who is often seen without proper clothing and things. I mean,
Yeah.
and somebody's tried to give her a coat, but no one seems to know her name. It's these sort of unknown.
Yeah.
And
I understand that.
Worrying.
I understand that. Yeah.
Thank you, Leslie, for bringing that to the attention. Richard?
Richard wants to come in. Yeah.
I was just going to briefly reflect. We touched earlier around things like questions of mental capacity, and I think what we're talking about is one of those very difficult areas where people have capacity to make decisions which might be decisions that we may consider, or to live a life that we may consider to be unwise or undesirable, but actually are entitled to make that decision. And it's only then when, I suspect what the pandemic has done then is make more clear some of the implications of that, so that if, for instance, someone isn't complying with social distancing or the wearing of a face covering, that's in a sense butting up against society in a way that previously it didn't do.
Yeah. Shall I just finish off, Councillor Salmon?
You can, yes.
Finish off, yeah. I meant to say it earlier, but I did say it, but it's really important. We have an infrastructure for the board. So we have a delivery group, which Penny Woodhead chairs for us, but she acts as the deputy chair of the board for me as well. And we have 3 subgroups. And one of the most important subgroups is the performance and quality subgroup. And it certainly is this year in terms of picking up a lot of these issues. So we have added 3 specific sections to the work of the quality and audit subgroup, which is, we have a new chair for that group. It's Paula Adams from Localis. The other great thing we've got is the sharing of chairing these groups is shared across the partners. When I started here 6 years ago, it was just the local authority chairing them. So they'll certainly be looking very closely at Section 42 inquiries and the trends that are taking place and the kind of issues that are arising. They'll be looking at the risk register, which will continue to develop. But I just wanted to stress more importantly, and it is new for us, we're getting really good stories, real life stories through Healthwatch and the reports they're doing. Healthwatch in Kirklees is a very high standard. And they are producing they've just produced a very balanced report which highlights some of the concerns and issues they find people are dealing with. And they don't just take a note of them, they help people sort them out. But also some of the good things people are finding, the good experiences they're having with their GP or their hospital or their social services. So they're putting a balance on things, which I think is really, really helpful. They've been producing data which they've been sending to me as it's produced, which I've been reading with great interest, and we took a report from them to the board last time, and we will next time. Okay. One final thing, Councillor Salmon. In January, fingers crossed, we'll be recruiting a new independent chair for the Safeguarding Board. And Richard knows there's been people are so busy, there's been a lot of trouble getting a date, but we think we got an interview date, don't we, Richard, by now? And this may be, and probably is, the last time I'll be presenting the annual report to you. But I just thought I should just say that and let you know. Okay.
Thank you for that, Mike, and thank you for everything that you've done for the board in your independent capacity. Richard, were you wanting to come in there? Sorry, you're...
No, not
right,
particularly.
okay.
Thank you.
Okay.
In fact, I need to offer an apology. I need to go to another meeting.
You do, yes. Okay.
Okay. So we think we've got some good candidates, so we shall get you a good chair. Okay.
Thank you.
Okay. Thank you.
Thank you for that. Okay. If we can move on to the next item, which is the work programme. If I can pass on to Richard to take us through that. Item 9, Richard.
Yeah, that's fine. Thank you. Thank you very much. It's going to be quite quick because what I wanted to do was just really focus on some of the stuff that we've got coming up for the panel. Obviously, as you're aware, we are quite heavily restricted in terms of the number of meetings we're able to host. Liz did mention, obviously, at the pre-meeting that if it's really needed, we will do our utmost to try and add in some additional meetings. But at the moment, working on the actual programme as it stands, our next meeting that we've got scheduled is the 10th of December. And then we have another one again scheduled in February, 18th of February. So I'm very conscious that there's obviously quite a lot on the work programme that we put together at the beginning of the municipal year, but has been largely, I suppose, been overtaken by events because we're very focused clearly and quite rightly on the impact of the pandemic. So a lot of the meetings that we've had have very much focused around that. But so we're just absolutely clear in terms of what we've got coming up for the 10th of December meeting. We will continue to have our COVID update. It's a standing item which you've all said you wanted, and I'm assuming you will continue to want until you tell me otherwise. Jane has already mentioned that she will come back and give some updates around some of the issues that were discussed earlier, and we'll obviously have a further update in terms of the data, etc. So that will be a continuous item. And then we've also got, and I'm touching wood on this one, the SWIFT mental health services coming back. Well, so not coming back, coming to the panel meeting specifically to have a real focused discussion around the impact that this pandemic is having on mental health services. I'm still waiting for final confirmation of who actually will be attending, but I have been given assurances by the trust that they will send some representatives. And so you're clear, what we're asking for them to do is to provide an update and an overview on the implications of the pandemic, to include a description of their sort of early response to service provision. We heard a little bit about what's happening from that today from Chris Lennox. We're also asking them to provide a sort of more detailed overview of the steps they've taken to mitigate the impact on their various services. We're asking for more details on the demand, so what the increase in activity has actually been on services. And we're also asking for more details, although Lynn did cover it a bit at this meeting, about what would happen if there was an outbreak in an inpatient psychiatric unit. So it may be that that one potentially might well have already been covered. So they're the two items. Unless you want anything more on, I think probably there's going to be quite a lot to talk about just in those two items alone. So I don't know if there's anyone got any comments, Councillor Zaman?
I'm okay with that, but I'm happy to listen to panel members if they would like to add anything to that. Dave, you have your
mute.
Because you see, just those items can take up roughly 2 hours that we allocate for the meeting.
Yeah, I just wondered whether there was any development in relation to the proposed mental health services workshop.
Yes, but to be honest, Dave, what's happened? This has kind of like overtaken events, if that makes sense.
Right.
So yes, we could have arranged a workshop, which would have been sort of like an informal type session. But the clear steer I got from members from when we talked about what you felt you wanted to include on the agenda plan going forward, that you did want to accelerate that and actually have that opportunity to have that sort of public debate and discussion with the mental health services. So we can still arrange one, but to be honest with you, it's a bit like, you know, the horse was already bolted in some respects. So you know, if you're still okay for them to come to the meeting in December, you will be able to have a very detailed discussion with them. But you're right. I mean, we were originally planning for that, but I think we've just to some extent we've run out a little bit of time to obviously get that scheduled.
Yeah, understand that. Thank you.
Okay, Leslie, would you like to come in?
Yeah, I just wanted to ask two things really. One is, what's the regulation about limited meetings? Obviously, I missed the pre-meeting. Sorry, I had another meeting that I was in that ran over. Because, you know, there's so much going on at the moment. And I just sometimes have a sense that we come to these meetings and we haven't got much time. We've got to hurry, hurry, hurry. And I know everybody's busy, but I also think we really need to be informed of some of the things that are happening. I mean, other people may not be engaged in these conversations, but certainly the HRI situation, and Peter, you alluded to it earlier. You know, if one thing that this COVID disaster has shown is that we need a functioning local hospital.
We do. I agree.
And I think that needs to be, you know, whilst we've not been meeting or whilst we've been in lockdown, because I'm a governor, I can't discuss all those things, but they're racing ahead with everything. And I just think there needs to be a big pause to stop and reflect, you know, because I'm really worried about the fact that we will not have a functioning, you know, accident and emergency, fully staffed in Kirklees.
Precisely.
Yeah, could I come in? Could I come in, Richard?
Yeah.
Just to say that the Calderdale and Kirklees Scrutiny Committee are meeting and have met, so it is being discussed by Scrutiny, the plans for the Calderdale and Huddersfield Foundation Trust, just to reassure the panel. Thank you.
I mean, I think there is a thing, Liz. It's really, and I know probably I irritated Vicky by hypothesizing, but those of us, at least I don't know what whether there's any real clarity of function on what an A&E will do in Huddersfield in the future. I've no idea what the total planned bed numbers are. I have no idea what the public consultation will look like, or if there'll even be one, which is why I raised the question, because it would be superb to sneak surgery under the radar and get rid of it, you know. Absolutely. So it's just the unknowns, I think, and which is why I asked about care closer to home, because if we've not got beds in Huddersfield, care closer to home has got to work, and
I agree. Care closer to home absolutely needs to work across Kirklees, Kirklees.
Yeah,
because we have that, but as far as the Calderdale and Huddersfield information is concerned, there's some public reports available, and we can share those with you. Okay.
Thank you.
Can I just say, at the same time, there is this increasing amount of privatisation, and it's just going by the back door, and it's not always being held to account. I mean, I can just speak for my partner who's having cancer treatment at the moment, and he's, pillar to post, and mostly, once the initial thing's done, it's the private stuff. And I know nobody wanted to ask the question about whether there is specific rates that the NHS pays or whether they have to pay full, it just feels like we're in this money-making machine, which is the complete opposite what the NHS was meant to stand for. End of rant. Sorry.
Thank you.
Okay. I was going to do.
I think Lynn's still waiting to speak.
Okay, I was just going to respond to part of Leslie's question, which was about the meetings, and just to make the point that we do have some light restriction in terms of the number of meetings we can support and host every week, which is currently restricted to 3. But we do from time to time make exceptions where there is a case to be made. So I guess what I'm saying is that if there were some issues that were really important that had to be discussed and had to come to scrutiny, and it didn't fit round the schedule that we've got, I think as has already been alluded to, we would do our utmost to ensure that we would get an additional meeting into the diaries, so that scrutiny is, afforded that time to have that debate and discussion. There is no particular time restrictions on these meetings, but we're obviously very mindful that the longer they go on, it is quite tiring for members, particularly doing it virtually. So it's kind of a balance really between making sure that we get the items that you feel are important to you, and we've got to really clearly prioritize, haven't we? Prioritize more than we've ever done before to make use of the time that we do have. But I do get your point, Leslie. I mean, the intention is not to rush things at all. We want to make sure that scrutiny does have the platform to have an honest and open debate and discussion to satisfy and reassure members.
Could I just add, Richard, I know I'm a bit controversial, but is there anything more important than bringing back the conversation about saving better services at our local hospital in the light of COVID? I cannot think of a more important and urgent thing that needs to be brought up again, rather than saying it's a done deal. It still has all to be ratified by the council, but I think that there is a bit more scrutiny may be needed for aspects of what's on offer and how realistic it is.
Yeah, and I think as Liz has mentioned, the Joint Health Scrutiny Committee do very much have that in its sights. Good. And I think what we'll need to do going forward is to ensure that any information that goes to the Joint Committee you are made aware of. So from a local perspective, you can see and you understand and you're involved in the work that's taking place there as well, because it is important that you have oversight of that, definitely.
Yeah. And the increasing amount of privatisation, it's worrying.
Mm-hmm. Thank you for your comments, Councillor Warner. Lynn, are you wanting to come in?
Yes, just very quickly, Chair, thank you. It's just to say that I think it is a good idea for now to postpone pursuing the mental health workshop, because things are being done very differently at the moment, obviously in response to the virus. I don't think we'd get the best out of it, but I would like to ask that we keep it as an option for the future, please.
Yeah,
I think we'd all benefit significantly from having a less formal interaction with mental health services, just really to get proper insight into what all the different teams do, because it is interesting and it does inform the role that we deliver on an ongoing basis. Mm-hmm. Thank you.
Thank you. Peter, are you wanting to speak?
Sorry, just one point, Chair, just one point to really follow down from what we said. And I think this will probably happen, just to ask Richard if we're going to receive kind of regular feedback reports on winter pressures. In previous winters, we have had an update from time to time from, Mid Yorks are very good at doing it, and CHFT have done it to let us know just how things are going, because we've considered it today, and very important that we did, and we've covered a lot of ground, but it's not going to stop here. It's and we are in this this great uncertainty, it's really a case of whether we can keep a finger on the pulse of it.
Yeah, no, that's very reasonable, and I see no reason why we can't do that. So I will make contact, as we've done previously, to see if we can get periodic updates. And they are, to be fair, they are also letting us know proactively when I'm having to take measures such as the closure of the Huddersfield Birthing Centre. They are proactively contacting us, as they should do, to let us know of any changes to services as a consequence of the pandemic.
Thank you.
Mm-hmm. Thank you. If there's no further comments, that brings us to the end of our meeting. Can I ask that we close the formal meeting, and then if panel members can stay behind, we can have a further discussion on another item. Thank you very much for everybody attending. Stay safe, particularly now that we've got a further lockdown for another few weeks, and hope to see you all soon.